right, once again, I'd like to welcome everybody. I know I have some people just settling in again, and we'll go ahead and get started. Good morning or good afternoon, depending upon where you are. My name again is Leanne Foster, and I am a member of the Provider Outreach and Education team here at WPS. And I want to welcome you to our Summer E&M Road Trip Navigating TCM Guidelines. So if you've been following Ashley's and my webinars in the last few months, you'll note that Ashley and I have began doing two-part series both on level of service but also care management services. Today we are going to be focusing on transitional care management services. And our objective today is to provide you with a better understanding of TCM services, or those transitional care management services, and their billing requirements. So today's session is going to focus on the base knowledge about TCM and what you need to know about transitional care services. Tomorrow, Ashley's going to be hosting one of her interactive sessions that's going to cover common rejections and denials for transitional care management services, but it's also going to allow you the opportunity to apply your knowledge and that you've gained today through an interactive activity. If you are interested and have not registered for that, registration is open through midnight tonight, and I have asked Ashley to throw a link in the chat for you to register that if you're interested and have not already. So again, with our task at hand today for that better understanding and billing requirements, today we're going to focus on both patient and provider eligibility requirements for TCM service. What constitutes that TCM service? It's really a preventive service when you think about it, because it is focused on providing, on reducing rehospitalizations and ensuring better health outcomes for a patient from an inpatient service, or inpatient admission. So we're going to talk about those eligibility requirements. There's also various components of TCM that we're going to run through today of what qualifies a service for transitional care management. And then we're going to spend some time on both the billing requirements and the documentation requirements. And for those documentation requirements, I do have some examples of documentation that's not fully supporting that transitional care management service that we'll go through, and we'll talk about what is needed. So I'm going to start with a TCM overview. So as I said, TCM is a valuable service that's intended to preserve the continuity of care for the patient that's transitioning from an inpatient back to the community, back to a home setting. And like I said, this is really a preventive service when you think about it, is trying to prevent readmissions and again, improve health outcomes for the patient. So Medicare may cover transitional care services if certain requirements are met. TCM is a care management service that is going to start after a discharge from an inpatient service. It is a 30-day service. And I want to just call that out for a second. It is a 30 calendar day service, and day one is the date of discharge, and the service continues for 29 days. All of the services for TCM need to occur in those 30 days from discharge, and it is a full 30 days. Again, it's intended to make sure that the patient is receiving all of the care that they need and eliminating any care gaps when they're transitioning either from a facility to a home or from provider to provider. They could be going from one facility to a different type of facility. And we are going to talk about what that looks like, what's considered a facility and what is considered that community setting that would qualify for TCM services. Some of the things that are included in TCM, we'll talk about these, but think about making sure that they have all of their appointments scheduled. They're not waiting for something to be scheduled for months in advance. Coordinating with other practitioners. Maybe there's therapy that they need post-discharge. Maybe there's community services that they need to be connected to. Maybe there's oversight in their medication instructions. And we'll talk about all this a little bit more, but while you might not be treating the patient and everything that's going on, you are coordinating their care to ensure that everybody is on the same page and making that transition simpler for the patient, because you're going to be the one practitioner or your office, you're going to be the one team that knows everything that's going on with that patient. Now, before I move on, I do want to address a couple of pre-submitted questions that fit in here really well. One question was asking if what happens if the patient gets admitted within that 30 days? What if there's a readmission? You just heard me say that we're trying to avoid those readmissions, but this is an excellent question because things can happen. It is a great question. So if that happens, if the requirements for the first TCM 30-day period are met and it happens, quickly within those first 30 days, that TCM service can be billed. With the readmission though, the 30-day service is disrupted. And so a new TCM period would start when the patient is then again discharged. And I mention that because you might have a TCM period that isn't necessarily a full 30 days. TCM just calls out that the services that qualify for TCM have to happen within those 30 days of discharge. So if they all happen within 20 days and unfortunately the patient was readmitted, if you still qualify for TCM services and you provided those services within those 20 days, they could still be billed, and then a new service period would start with the next discharge. So benefits of TCM, as I said, it's a care coordination service, making sure that the patient's transition, whether that's home, whether that's to some other community setting, is an easier transition after that inpatient stay. It is meant to ensure faster access to follow-up care because there's oversight. The patient isn't having to reach out and make the appointments or connect to services. Somebody has oversight in making sure that it's happening in a very timely fashion, and we'll talk about that. Patients and caregivers will receive more support as well through education that's coming from the providers and their auxiliary staff to ensure that they're understanding what the next steps are after discharge. We all know there's usually a long list of things after an inpatient discharge that a patient and their caregivers have to keep track of. TCM is providing support to make that smoother and a little bit less confusing. And because they're getting all of their follow-up care, because there's oversight into making sure that they are adhering to those post-discharge instructions, the goal is that it improves their likelihood of recovery and reduces those hospital admissions. So I want to talk about what an inpatient facility stay qualifies for the potential of TCM management services. We did get several questions asking what can trigger TCM, and what triggers it is really that discharge. It's a 30-day service. Services have to happen within those 30 days. But the example I gave earlier, it might not necessarily be the full 30 days. If they readmit, hopefully they don't. But if they readmit, then that could trigger yet another TCM. So it's not a once-a-year service. It's a once per qualifying discharge. And it's those 130-day period post that discharge. So the types of facilities that would qualify would be your typical inpatient hospitals, those acute care hospitals. It could be an inpatient psychiatric facility. It could be an inpatient rehabilitation facility or an IRF. It could be a long-term care hospital or an LTAC. It could also be they were discharged from the hospital for outpatient observation, or it was a partial hospitalization scenario. So those qualify. They are being discharged with generally a discharge summary and some next steps. One thing I do want to call out, and we'll talk about this a few times, TCM services, though, do have an expectation of a moderate level of medical decision making. I just want to call that out here. So it's definitely discharged with some next steps. It can also be the discharge from a Part B skilled nursing facility stay, because they're transitioning again back home or some domiciliary arrangement. They're discharging somewhere, and how do we manage that transition? So the next piece is what does home look like? What's that community setting look like? So the patient's going to be discharged to their home. their house, their apartment. They could be, again, that domiciliary care. So if they're in a group home or a boarding house, it could be that they're going to a nursing facility. And I just want to call out that this is not a skilled nursing facility. This is going to be a nursing facility that's not a Part A qualified stay. It's going to be when they're shifting from that skilled nursing facility to nursing facility. They might not leave the skilled nursing facility. It could be they're just basically reclassified as now being in that nursing facility. So keep that in mind. Can also be that they're discharging to an assisted living facility. And these are laid out. We'll go up to that MLN in a little bit, but these are laid out there. So next, who can provide these services? So what providers are eligible to provide these services? So the first list is going to be your billing providers. These are the providers that are actually going to bill for the TCM codes. We'll talk about auxiliary staff in a bit, because auxiliary staff, they can bill incident too. But in general, who can provide the services? First, it's going to be the physician and any of those non-physician practitioners. So it's going to be nurse practitioners, physician assistants, nurse specialists, and nurse midwives. They can all provide those services. But in addition, your ancillary and your clinical staff can assist with these. In fact, they're going to play a really important role in these. They're going to be involved in those services because there's components such as some of the contacts that they're going to carry out. And we'll talk through that, but they will have supervision requirements. Those auxiliary and clinical staff that are not going to be billing for those codes are going to be providing those services under Incident to guidelines. These are the typical Incident to guidelines, as with any other Incident to service. The billing provider is going to be, again, those healthcare providers, but the auxiliary and clinical staff can assist. They have to have that contractual or employment relationship, and those services are going to have to happen under general supervision. Again, just with any other Incident to service. We do have some other sessions that we've done specific to Incident to if you need more information, but we're not going to go in depth into Incident to today. The other thing with Incident to services is these staff do need to be following that billing provider's plan of care. They're not creating the plan of care. They're certainly going to be communicating with that billing provider, but that plan of care does need to be created and managed, revised by that billing provider. This isn't going to be something that's handed off to the ancillary and the clinical staff. There still needs to be that oversight. And then certainly any clinical or ancillary staff that are providing these services, then particularly those non-face-to-face services, they do have to be providing them within the scope of their state law's scope of practice. And that's something that can vary by state to state. So you'll need to make sure that providing services that they are qualified and allowed to do. So let's look at the TCM components. There's a list in the MLN that talks about these components in a little bit more detail. But again, remember these, I want to talk about some of the key components here, and then we'll talk about some other things that fall into those. So again, remember, this is a 30-day service. It's a 30 calendar day service. So it's services that happen within 30 days. And it starts with discharge being on day one. The first and foremost is going to be an interactive contact, and we'll talk about that, but that's going to be an interactive contact between the provider's office and the patient. You're going to also have face-to-face care, which is going to be what we get into when we get into the billing components. There are codes specific to TCM that you will bill. So we will be billing for that. And there's also going to be non-face-to-face care. So those things that you may be managing over the phone, those things you're doing for the patient to connect them to various services, those are all going to be things that count into TCM when you're deciding whether or not you have a TCM service. And then there's also going to be medication reconciliation and management. We all know that somebody leaves the hospital, they've probably come home with some changes or additions or even deletions to any medications that they're on. And we want to, part of TCM is also making sure they're not taking too much medication. Maybe they're on multiple medications that are essentially the same thing, which could cause them to have some type of overdose on that particular medication that could impact their health status. We're trying to avoid all of that. So we're going to start by going into that interactive contact. And an interactive contact is something that has to happen pretty quickly after discharge. It does have to happen within 2 business days of discharge. Now, we've been talking about TCM being a 30 calendar day service, and it is, but this is where it shifts just a little bit. This interactive contact has to happen within 2 business days. So if you have a patient who discharges on Friday, it would really be Tuesday before you'd have to have this, because Saturday and Sunday aren't going to count. So you want to look at those 2 business days. Another example without a weekend would be if they're discharged on Monday, they'd have to have this interactive contact by Wednesday. So it's gonna, in calendar days, it's going to be quicker, but that is because, again, we're talking business days, and Saturday and Sunday don't count. So that is something to keep in mind when you're timing these out, but that has to happen or you do not have TCM services. We do get questions on what has to happen in this, and this is where they're developing the patient's medical status. How are they doing? What are their needs? That you're assessing what's going on. You may be scheduling appointments, but you're not just scheduling an appointment. You're really starting to dig into what they need to transition. This is something that can be performed by clinical staff, and it's happening under incident 2, so it can be. We also get questions about attempts. Patients just discharged, maybe they're resting and you're not able to get a hold of them. Document your attempts, and you should be making those attempts until that face-to-face visit happens. But make sure you document them. We've had documentation come in where they're telling us maybe that they called, but we don't know when. We don't know the timing of those calls. We also know that we have documentation where attempts are not being documented. We need to see that attempt. So along with that, we did get some questions about documenting that call. So one of the questions was, how does the 2-day phone call need to be documented in the chart? So like I just said, it just needs to be documented. You want to document in that medical record, you want to include the date, the time, who you spoke to, or if it was an attempt, and then what was discussed. So we need to make sure what was discussed. I'm not asking for a transcript of the call, but that high level, just maybe a high level, even a bullet list, but just a high level summary of what was discussed. Another question that we got was asking if a provider portal with 2-way messaging, that type of conversation, would that count towards that 2-way interactive contact? The answer here is it could. It depends. So if that conversation is interactive, which means that it is completed and acknowledged by both parties, it could count as that 2-way interactive contact, provided that you're talking about patient's medical status, their post-discharge needs, not just an appointment reminder, not just your appointment has been scheduled. It has to go beyond that scheduling piece. Now, if you just send the message and there's no interaction, that's not going to qualify. So you really want to look at those and see, is there 2-way interaction represented in that conversation? Most oftentimes these are phone calls, but there are options if they meet the requirements. So the next component I want to talk about is going to be those non-face-to-face services. As you'll hear me say a few more times yet today, this is a 30-day service. So you want to make sure that, if you're continuing to offer those TCM services, the level of effort that's in those services could change the code build. So you don't necessarily want to bill it right away. You want to make sure you've provided all of those services. And it's not something that restarts after those 30 days. So make sure those services are all happening within those 30 days following discharge. Again, date of discharge is day 1. Non-face-to-face services, these are again the services that can be performed not only by the physicians and the non-physician practitioners, but clinical and ancillary staff as well. The billing practitioner, those MDs, DOs, MPPs, they need to review the discharge information. And we did get a question about that, which is a fantastic question, asking if they need to review that discharge information. And the answer here is yes. This is really going to be that roadmap to what you're going to be managing, what the patient's needs are going to be, what transitions are you managing for that patient. Now, it could be a discharge summary, it could be a continuity of care document, but it is going to be some type of discharge information that is reviewed. Without that, it's, again, not really discharge that transitional care management, because you're not managing that transition, because we need to know what is in place or what needs to be put in place after that discharge. The practitioner also needs to be reviewing any open diagnostic testing that maybe hasn't already been reviewed or entered into the facility's information. So they're tying up any loose strings that might be left from that patient's discharge. This can include interacting with other healthcare practitioners that were involved in the care. So it could be coordinating services. So what are those other providers doing for that patient? Do they need to go see cardiology? Do they need to go see the osteopath after their discharge? Making sure that those visits happen or are scheduled. And again, remember with TCM, the billing provider is not necessarily treating everything that's going on with a patient, but you need to know the care plan of others, because you're coordinating all of that to make sure there's continuity of care, there's no gaps, but also there's no overlaps. Again, coming back to that medication example. And this management can include not only their medical health, but if they have any mental health needs, that's something that is a big piece of this as well. As I said, this is something then you can involve your ancillary staff and your clinical staff, but they're going to be more involved in communicating with the patient, educating the patient and their caregivers on the care plan that your practitioners are developing. So they're not going to be necessarily doing everything that can happen non-face-to-face, but they will be assisting with it in a big way. Like I said, they are a key component. And with that, I do actually want to take us out to the MLN. And I'm going to start at the CMS website. And don't worry, there is a link in the training material for this, so you will have a link to that booklet. So I am going to go into training and education, and I'm going to go to the Medicare Learning Network, resources and training. And let's go into publications. And I'm searcher. So this booklet here, and again, you will have a link to that. This is a great resource when you're considering whether or not your service meets transitional care management, or if it's something that you haven't offered before, it is something to consider. That is one thing that you'll see in Ashley's session tomorrow's the data, is that this is something that's a bit of an underutilized care management service that we want to promote. So if you are going into TCM Components, was the link that I went into. And here what you'll see is with the non-face-to-face services that we're talking about, they have a really nice list that breaks down what the physicians or NPPs are going to be performing or expected to perform, and then what your auxiliary staff under supervision can provide. So if there are any questions, this is a great resource for that. So there's also a face-to-face service that's going to be billed by the billing practitioner. So again, in those 30 days, this is something that's going to be billed. And it's not going to be billed by the ancillary staff. Everything that they've done is going to happen incident to and roll up into this. So with this service, it does have a timeline component. So if you have a moderate level of medical decision-making, it's something that is happening, that face-to-face service is happening within 14 calendar days of that discharge. If it's high level of medical decision-making, it's happening within 7 days. And this is really going to depend on everything that's going on with that patient. We also get questions on whether or not this can be performed by telehealth, and this is something that can be done via telehealth. But it's really about what's going on with the patient. The last component I want to talk about before I go into the billing components of this is medication management. So this is looking at all of the medications and asking, are they all appropriate? I mentioned earlier, when people leave an inpatient or are discharged from an inpatient stay, there are going to be changes, additions, deletions, adjustments of some sort to their medications, most likely. And this can be a big deal. We want to make sure that we're looking at everything they're on to make sure that they're not taking too much, too little, they're taking it appropriately. If it's changed how they would take a medication, this is also how we're going to assess their adherence to that. So we want to make sure that we have that. Typically, this is going to happen on or before the in-person service. Because you're looking at those discharge instructions, you're looking at everything that's going on with the patient. So what are they on? What were they prescribed from the facility? What were they on before they went to the facility? Are these medications working together? Are there some contraindications we need to consider? So you want to make sure that you're doing that. It can be performed by the physician or the nurse, non-physician practitioner. The clinical staff may be having this conversation and assessing this during their interactive call, but certainly they're not going to be making decisions about things that are anything that's got to be changed, but they can make that assessment and then they can communicate with that practitioner. So next we're going to move on to billing requirements. So there's some key components to this when we're looking at this. First, only one provider is going to be able to bill for this service following the discharge. They've been discharged, one provider, physician, non-physician practitioner is going to be overseeing their transition back into a community setting. They may have those auxiliary or clinical staff providing services underneath their supervision, but only one is going to provide it. Now, I want to go back to that example that I had earlier where a patient was discharged. They are in a transitional care management period. All of the transitional care management services or requirements were met, say, for example, within 20 days of discharge, but unfortunately, the patient then went back into the hospital. This is where it can get a little bit of a gray area because it's one provider per month for transitional care services. They may be able to bill for that first discharge where the services were provided within the 20 days, but the other provider on the next discharge wouldn't be billing in that same month. So you'll have to look at timing, but it is one provider per month that can provide transitional and bill for transitional care services. You're also only going to bill it once per patient. So this isn't going to be something that you're billing every time you have an interaction with that patient. You're billing it as that 30-day service. One per patient, once per month, one provider per month. Also want to call out that it's not going to be billed by the surgeon during a global period because these services would be seen as part of that global period. Typically, this is going to be somebody who's maybe their primary care provider. They're not the the surgeon that performed the surgery and their primary care that's managing the transition. Not, again, necessarily treating the patient for what's going on, but they're managing the transition. There is a difference. You are going to find there's going to be situations where concurrent billing may apply, and we're going to talk about some of those situations. And also, you can bill a separate E&M when medically necessary. So if it is as a distinct and separate service, maybe you have their transition and they have a medically necessary visit for something completely unrelated to that discharge, you may be able to bill that. So keep that in mind. It's not replacing those. So with the codes, as I mentioned before, you have to have a moderate or high level of medical decision making in order for it to qualify as a TCM service. So if it's low or straightforward, that's not something that's going to have a real complex transition. This is for those more complex transitions from that inpatient stay to that community setting. So there are two codes that are generally used for this. 99495, this is going to have required elements that include that communication with that patient or caregiver within 2 business days of the date of discharge. Again, business days, so weekends don't count. And then it has to be that moderate level of MDM. And this visit has to happen within 14 calendar days of discharge. So it has to happen. You have a little bit more time. That's a lower level of medical decision making. The patient's situation is a little bit different. So that is something that you will look at. If your patient, I just want to call this out before we move on to high level, if your patient doesn't need a moderate or high level of decision making, you're not going to have a TCM service. But what you may have is a regular medically necessary E&M. So it doesn't mean the service can't be billed. It's just TCM is coded and priced differently. The next code that you could use is going to be for the high level of medical decision making. And this is going to be code 99496. Now, documentation in both of these is going to have to support that level of medical decision making. If you're interested in more information, Ashley and I did do some 2-part series this summer regarding choosing that level of service, if that would be of assistance to you. And those are out on our website at this point as well. But the required elements for the 99496 are going to again be that 2-day interactive communication with that patient or caregiver within those 2 business days of discharge, and a demonstrated or documented high level of MDM. And this is going to be something that requires a face-to-face visit within those 7 days of discharge. One moment. Would not want to switch for me. Now, there are going to be some times where you may be able to concurrently bill for services. There are other care management services that can be billed at the same or in the same month as a TCM service. I'll show you that list here in just a minute, but some of the key components of that are that the service has to be medically necessary and reasonable. You cannot count activities or time spent on TCM twice. So if you're billing other services in the same month with TCM, documentation has to support each service separately. So just like you're using a modifier 25 for multiple E&M services on the same date of service, documentation has to support each service separately. So you want to separate the two. Same as here. Some things that you commonly see, I just mentioned care management services, but also end-stage renal disease, so an ESRD. And again, that documentation has to support. So I want to take you out to the MLN. And here is a nice chart for concurrent billing of MDM. And what it does a nice job of is listing out those codes that are considered separate. They are considered a reasonable amount of effort that doesn't necessarily factor into TCM. So these are those codes. Here's those end-stage renal disease codes. There's quite a few of those. And then you get into, I apologize for the scrolling. There are some caregiver training services that could also be billed separately, some remote therapeutic monitoring. Depending on what's going on with the patient, you may be billing these as well. And then I want to get to the care management so you guys can see that chronic care management is on this list as well. So it's not necessarily an either or for some of these other care management services, but it does depend on what's going on with the patient. I do want to talk through some things that are specific. We often get questions about RHCs and FQHCs. So RHCs and FQHCs can submit for transitional care management, and then they would be paid under, for an RHC, be paid under that all-inclusive rate or that air rate. And for an FQHC, you'd be paid under that PPS or that prospective payment. But it would be paid if it is billed separately from that typical service from those facilities. If it is included as part of another encounter submitted on the same day, that would be the exception. Again, it falls into the category for our providers that aren't RHCs and FQHCs. The documentation has to support the services separately, and you're not counting them twice. Next, we're going to move into documentation requirements. Now, documentation requirements for TCM are going to have a lot of similarities to all-around documentation. We need to know what happened in that encounter. We certainly don't necessarily need a novel, but it does need to be clear. It does need to support the level of code that is billed. But with TCM, we do have some tips for what we would be looking for that would help us qualify it as a TCM service. So what we're looking for is the dates of the discharge. That's going to help us establish that 30-day period. When did the TCM period begin? So when would that eligibility have started? We do need to see that interactive contact, not just that it happened, but we do need to know the date that it happened, because again, there's that 2 business day requirement. So that date's going to be pretty important. Same with the face-to-face visit, depending on that moderate or high level of TCM. We're going to need the date that that happened so that we can see that it happened. Because remember, you're going to bill for that TCM. We do need to see what services, what TCM elements were included. So what coordination of care happened? What services was the patient connected to? What non-face-to-face services happened? We want to make sure that those elements happened. And it's not necessarily every element of TCM. Certainly that interactive contact and that face-to-face have to happen, but we're looking for a minimum of 3 of the elements listed in that MLN. Give me 1 second, out to that. And I apologize for the scrolling here. This is MLN 908628. Okay. And when you're looking at the components, this is where it will talk about which components. And there's obviously more than 3 here. It's not necessarily always going to be every single one of these services. It's going to be what makes the most sense for the patient. But again, we do need that 2-day interactive and that face-to-face. So I want to take a look at a couple of examples. I have 2 of them, and there are multiple pages here, so we'll break that down. So here we're on example 1, and this one we do have our date of service. They have their date of service, the date of discharge is there. It's 10/27. There are older examples, but these examples do still fall into TCM. We do also have an addendum that's showing that they were looking at lab results. That information is in there, and we are finding that there are follow-up instructions. So they have in that update, that's going to be that middle green box, they're showing that they are faxing information to another doctor, notifying them of that they need following up with their nephrologist. So again, they're coordinating that care, not leaving it to the patient to do it. They're showing that management. So far, so good. Here they do have the problems identified and the history, probably from looking at that discharge note. Those are the kinds of things that we want to see here. This would make sense. They are going to talk about where their healthcare status is at this time. So they're discussing that, just like you would with any other piece of documentation for a regular E&M visit. On this page, we do have the encounter reason, and the practitioner is calling out that they don't know if the patient has been set up for cardiac rehab. If they're billing TCM, that's the piece that's a little bit of pause in this example. They don't know if they are set up for that. If you're doing TCM, you would know that you're set up for that, or you'd be documenting that you have reached out to set that up, because again, TCM service is about managing that transition of care. You know what's going on, and if something's not happening as it should, they're facilitating that it is happening. Couple of things that we also don't know from this one: who ordered the cardiology, what's the plan with the cardiologist, why are they going? So there's just not enough to support that this visit, they're in for a skin check. There's not enough to support that it's post-discharge, but that this provider is actually coordinating their care. On the next page, they listed that there are some pending tests or labs, and that those were followed up, but what were they? What are the results? What's going to happen next? Or what could happen? Obviously, you've got to review those results. But again, it's coordination of care. So we need the who, what, where, when. We need to know what's going on. It looks like in this one, they came in to have lesions that were being treated. They had a discharge, but there's not enough here that's supporting TCM. However, they may have a separately identifiable E&M, or they may have a regular E&M. The other thing that happened with this particular one, that they submitted TCM and they added a 25, and that's not something that's necessarily appropriate. Remember that 25 is going to be on that separately identifiable E&M service. They're not going to submit that with a TCM. So here were the findings. There was some good, and there was some not quite as good and not quite there items in this documentation. So the things that this documentation did well: they showed the services that were provided following the face-to-face visit. They were talking about the nephrologist. They talked about that. They did show that discharge summary was reviewed. It was part of that history. It did support a moderate complexity of medical decision-making. If you dig a little bit deeper, that was supported when our review staff looked at this. What we didn't have was coordinating the care with the other practitioner, the cardiologist. They didn't know if they had set that up. They hadn't actually gone that extra step, taken on that extra effort to coordinate those for them versus just reminding them. We also didn't have any medication reconciliation in this one. They came in for a skin check. They didn't look at all of their medications to see what stays, what shouldn't stay, or is everything okay? What modifications had to be made post-discharge? They didn't really look at it from that perspective. And then we didn't see anything that was supporting education to the patient other than make sure you follow up. It's not quite the same level as what's TCM. So this would not qualify a TCM visit. There are, again, some very good things here, but it's not quite there. The next example is going to look a little bit different because again, we do not have templates for these examples. So looking at a little bit of a different setup or template that's being used, set up by an office that's being used. We have some good things. We do have, excuse me, we have a date of service, we have the exam and history, but there is a little bit of concern here with some of the canned language. There is some canned language in here a little bit further on that talks about I have reviewed all hospital documentation, consults, progress notes, and imaging, and I've discussed hospital course and follow-up care. It's not necessarily a no, but you've got to be careful when you're using canned language. CMS doesn't say you cannot use that canned language, but it might not be a best practice. Make sure it is supporting what's going on with that patient. But here we did have some exam and history. We are seeing some interventions, and we are missing coordination of care that was documented. They do have talking about advising them to follow up with gastro for an outpatient colonoscopy, but there's no coordination, there's no interaction that's documented. On the second page, we do have the assessment and we do have the plan. We do get that canned language again where answered questions. What were the questions? What were the responses? What was the patient advised? Again, not necessarily a dissertation of the conversation, but it can't be just a summarizing statement. We need to know that it's related to that discharge and that it qualifies for TCM. So this one, it definitely supported a moderate complexity of medical decision-making when you get into the different components, but again, we're missing a medication reconciliation. There isn't documentation of that interactive contact within 2 business days of the discharge. So that's a component that was missing here. And there's not any documentation of interaction with other healthcare professionals. Again, there's the call out of reminding them, the patient, to reach out, but with TCM, it's really going to be that provider themselves that's coordinating that post-discharge. It's that extra level of effort and work that the provider's putting into that care. So here, when you get your presentation materials, again, those are going to be sent out to all participants or all attendees after the session today. They'll be sent out once we can confirm that attendance, so you will have all of these. But here I have included links to CMS's page on care management. This does have some information on TCM, but also other care management services. If you want to look to see if your service doesn't meet for TCM, it could meet some of these other care management services. The second link there is for that transitional care management service booklet that we've been going out to. I'm just going to go out to that again. That links you here. And again, this is a really good resource that goes through everything that we went through today. It also has some additional resources, and some of those are also in your presentation. So here's that care management page. I'm just going to go out there and show you what that looks like. So it has chronic care management, advanced primary care management. It's also going to include some links for my federally qualified health centers, my FQHCs, and my RHCs, my rural health clinics friends, so that there are some resources out here specific to you as well. Also in this list of resources is an FAQ about billing transitional care management services. I'm just going to go out to that. Give me one moment. So this is an FAQ that has some of the commonly asked questions for transitional care management. And actually, one that I do want to point out is what the date of service should be on the claim. It's not something that is included in that MLN article at this time. Ashley is part of a group that goes through CMS's products, and her and I have been asked to look at TCM. Ashley was asked, and we did look at it, and we did make suggestions of getting this added to that booklet. So hopefully that'll be something that's out there soon. But here it will talk about the date of service. So that 30-day period that is beginning that date of discharge and can continue for the next 29 days. The date of service is going to be the date of that required face-to-face visit. So not necessarily date of discharge, it's when they have that face-to-face visit. And remember, that has to happen within so many calendar days. But that doesn't necessarily end the TCM services. You may be providing some of those non-face-to-face services after that. So at 14 days, you're not necessarily done. I would recommend the date of service is that face-to-face visit, but I would recommend not billing until you know you've provided all of the qualifying TCM services within that 30 calendar day visit. All right. So with that, I do have one more pre-submitted question, and then I'll check in with Ashley. One of the questions that I got was whether or not there's an age requirement for TCM, or is it just that the patient is Medicare eligible and have been discharged? And the answer is there is not an age requirement. If the patient is Medicare eligible, they are eligible for TCM. Typically, we're looking at providers or patients that are likely 65 and older, but you may have a patient that has ESRD or is disabled at a young age. So it is possible they're not 65. So there's a lot of reasons a patient can be on Medicare, but if they're Medicare eligible and the service is reasonable and medically necessary, they're eligible for TCM services. Again, it's just that 30 calendar day visit. So with that, Ashley, I am going to check in with you to see if we have any questions that have not been answered in the chat.
Leanne, we have not, let me double check. All questions in the chat have been answered.
Okay, well, thank you all. I know questions were coming in. Thank you for those. We appreciate that interaction. And I know because Ashley was answering those in the chat, not everybody saw those, but we will be sending out a follow-up document that includes those questions and those answers. We're also going to be taking questions for the next 7 days after this webinar. So you have until next week. If you think of something, please feel free to send that question to our education mailbox, which I've asked Ashley to throw in the chat for you. Just make sure that you're including the title or something close to the title for today's session so that those monitoring that mailbox know to get those questions to Ashley and I to get you those questions. If it's specific to a claimant process, that still has to go to customer service. But if it's about TCM, that is a question that we'll certainly take. Also, remember to register if you haven't already for Ashley's part 2 of TCM management services tomorrow. That's going to be that interactive activity, another opportunity for questions, but also we'll talk about some denials and rejections. So you'll be able to apply your knowledge today. So we hope to see you there. With that, I want to be respectful of everybody's time, and I know we're getting close, so we'll go ahead and wrap up. So in a few minutes, you are going to be receiving an email thanking you for attending. Don't delete that without reading that email. It's going to be 2 things. It is your certificate of achievement. It is also an opportunity to take that survey. 2 things there because we've changed how we're sending out the presentation. If you do not get this email, don't worry. Once I confirm your attendance, I will be sending you out an email with that presentation that will also serve as your certificate of achievement. So you will have that certificate. While we don't issue the CEUs, those contact hours, those certificates can be submitted to your certification or accreditation body to count towards your continuing education credits. Also, both emails are going to include the survey link. And we would very much appreciate hearing from you. We want to know what we're doing well, what we can do to better support you. And certainly we want to know what you would like to see more educational events to help make your life working with the Medicare program a little bit smoother and simpler for you. So a couple of ways you can do that. Like I said, it's in that email. Ashley also just placed a link in the chat. And when you leave today's session, you are going to get a pop-up box that is a redirect. It's not malicious, it's not spam, it's not taking you anywhere you don't want to go. It's simply telling you you're leaving our webinar software and going into that Qualtrics, CMS Qualtrics survey software. So again, we look at all of that feedback. It's super important to us. And please, I encourage you to feel to leave any comments that you'd like us to have or topics that you'd like us to see. So with that, that will end our presentation today. On behalf of myself, Ashley, and the entire WPS Provider Education and Outreach team, I would like to thank you all very much for attending today. I know we're all super busy. It can be hard to carve out this time. So we hope you're finding these sessions valuable, and we hope to see you in our session tomorrow. With that, have a great day. You may now disconnect.